Good morning and a very warm welcome to everyone who's taken the time to join us this morning as part of our webinar in respect of our Maternity Matters series at Irwin Mitchell. My name is Julianne Moore and I'm one of the partners at Irwin Mitchell, and I have the pleasure of being your host this morning for the webinar together with my colleague Anne Kavanagh and Sarah Williams. The concept of the Maternity Matters series is to look at the current and key issues which are pertinent to maternity and postnatal care. And we wanted to use this webinar to bring an opportunity to bring a community of people together, key participants in maternity care, such as patients, their families, healthcare professionals, key stakeholders such as trusts, together with maternity and birthright charities who provide support and guidance to raise awareness in respect of maternity care. Today's webinar will focus on decision making in maternity care, the importance to ensure that patients are front and central in the consent process. It will hopefully also provide tools for healthcare professionals in respect of consent, with the aim that there is supportive care for patients and their families in the order to achieve safer outcomes for all involved. You'll see from the information you've got about the webinar, we've got a really fantastic panel today and a number of keynote speakers who will present during the webinar. Our first speaker is Nadine Montgomery, and Nadine will look at consent and decision making from a patient's perspective, and she will share her story in respect of this. Now, Nadine may be familiar with many of you, as it was her long and fought legal case in the case of Montgomery and Lanarkshire Health Board, which went to the Supreme Court, which powerfully affirmed a woman's rights to autonomy in childbirth. Following on from Nadine, our second speaker is James Baynock QC, who is a very experienced and eminent medical negligence barrister, who will talk to us about consent from a legal perspective and provide some practical guidance around consent, which will hopefully assist healthcare practitioners in this field. We'll then have a comfort break, and then we'll move on to our third speaker, who is Dr. Rebecca Moore. Rebecca is a consultant psychiatrist who specialises in perinatal care. She's also the founder of the charity Make Birth Better, and Rebecca will talk to us about the psychological impact of birth trauma. Our fourth speaker is Maria Booker from the charity Birthrights, and Maria leads the policy and legal hub at the charity and manages their training for healthcare professionals and peer supporters. Maria will talk to us about the I Decide consent tool and how that can be used to assist in the consent process. Our fifth speaker is my colleague Sarah Williams, who's one of our medical negligence solicitors at Irwin Mitchell, and Sarah will share some further clients' perspectives in terms of case studies to reflect the importance of consent during maternity care to ensure safe outcomes. And then finally, we'll move on to our panel discussion, where there'll be an opportunity for our speakers to answer and address some of your questions. There's just some practical tips in respect to the webinar. Can you ensure that your microphone is on mute? In terms of questions, because the webinar is obviously condensed into 2.5 hours and we've got lots of speakers, after each session, there won't be an opportunity at that time to ask the speakers directly a question regarding their presentation. However, as we've created a panel discussion made up of the speakers, you can submit questions throughout the session and the webinar via the Q&A function on your screen, and we'll answer them during the panel discussion. This webinar is being recorded as it's a virtual event, and it will be sent out afterwards to everyone who's signed up to the webinar. At the end of the session, or towards the end of it, we'll be posting a feedback link, and we'd be grateful if you could just take 2 minutes to let us know your feedback on today's webinar, and also be helpful to know what further topics in respect to maternity care you would like to hear in respect to future forthcoming webinars as part of this series. So that's the introduction. And I'm going to now introduce our first speaker, who is Nadine Montgomery. As I've explained, Nadine is going to talk about her story from a patient's perspective and the importance of consent. Nadine is a champion for women's autonomy and consent in childcare, and many of you may be aware of her case in 2015, which went to the Supreme Court, which thankfully affirmed women's rights to autonomy in childbirth. Nadine will now talk about her experience and we'll talk about the case. So I'll hand over to Nadine. Thank you.
Anyway, there is a lot of feedback for me, so this is quite difficult. I don't know if you can hear me okay. I'm sure someone will tell me if you can't. It's like double playing, so my voice is speaking, but it's replaying, so bear with me. Thank you very much, Julianne. Thanks for introducing me. And I think maybe it's nice to bring a patient perspective into what the situation is, obviously from the people that are experiencing these things. And my journey began 20 years ago, well, 21 years ago now. Sam is 21 now, and I'm hearing back. This is really difficult. I'm sorry. He was born with cerebral palsy following a very traumatic birth. I want to emphasise that this wasn't about blame. It wasn't about pinpointing a doctor. Obviously, yes, I was very angry about what happened, and it shouldn't have happened. But it was really important wanting to understand what happened, why it happened, and to make sure with every fibre of my being that this never happened to another patient again. And I think there are times in life when you have to stand up for what you believe in, and this was one of the times. And the background to the case is I have type 1 diabetes, and I grew up, I was diagnosed when I was in primary school for many, many years. And when I was much older, 24, married, I was pregnant with my first child, and I was told that I would attend what was back then quite a novel concept, a joint diabetic obstetric clinic. And it was like sold to me this most amazing clinic with all singing, all dancing treatment, and you would see 2 consultants and all the midwife staff and the diabetic nurse specialists. I mean, really, the care was absolutely outstanding. I actually have my appointment card. I don't know if you can see it, but you can see just how many appointments I had throughout the whole pregnancy. And most times I saw 2 consultants. So I felt a bit like almost smug, like how lucky am I? You know, I'm the best of care here. And from 32 weeks onwards, I was having, before that I was having fortnightly ultrasounds, but from about 32 weeks I could see on those scans that my baby was becoming very, very large, and he was growing rapidly despite meticulous blood sugar control. And that gave me cause for concern. And, you know, I would ask at that point, what does that mean? He's getting really large, what, you know, but I was always reassured, you don't need to worry, we're looking after you really closely, we're taking good care of you. I did raise my concerns repeatedly, particularly about my ability to deliver him, given I'm only 5 foot tall. But I was told again, don't worry, we'll monitor you. And at 36 weeks, I was told that my final scan at 38 weeks would be cancelled because of my anxiety towards the size of the baby. Instead, I would be brought in for induction. So at 38 plus 5 days, I was brought in for induction. And I went into labour really quickly that evening, and I was taken to the labour ward. And it was quite a long labour. It was augmentation, oxytocin, and due to progress, I was told that we would proceed the following evening to theatre for a trial of forceps. And at this point, I was brought a bit of paper, and I was told to sign this bit of paper. And it was just really trial of forceps signature. That was the consent form. And still at that point, no risks had been discussed. I still had no real understanding about the procedure being proposed or any potential complications that could arise. So in theatre, they attempted to deliver Sam by rotational forceps because his head again wasn't even in the right position. So Keelan's rotational forceps. And I don't really remember much, but I remember a lot of time passing and a lot of silence. It's not a very exciting story. I think people had sirens and alarms and people rushing about, but it wasn't like that. It was very calm and very quiet. And after what felt like forever, I'm sure it wasn't, the anaesthetist came over to me and she told me, we're just going to put you to sleep now. And I think that was the first point I realised something was really very, very wrong. So I woke up, I don't know how many hours later, in a lot of pain and to the tearful faces of my family, and I knew something was terribly wrong. I was told that I had a baby boy and he was in the special care baby unit. He was very, very unwell. The nurses were amazing. They got me Polaroid pictures almost every hour, updating me with what was going on, but I was too unwell to go and visit him or even process what was happening to me. It was a strange time to see your baby for the first time, like almost joy, but complete sadness as well, because he was ventilated, had wires and tubes, and it just was a horrendous picture to see. It was only really in the coming days that I found out what happened. And what happened was, in theatre, Sam's head had been delivered, but his shoulders became stuck, which is called shoulder dystocia. I found this out obviously after the event. And he was stuck for a period of 12 minutes. And during that period of 12 minutes, several last measure resorts were attempted, such as to break his clavicles in order to fold his shoulders and pull him out, which was unsuccessful. An attempt was made to push his head back in, which was unsuccessful. I have no doubt that the fetal head sustained more damage during this time. And finally, 2 attempts were made to break my pelvic bone or cartilage, but on both occasions the scalpel blade detached. My consultant says that one surge of adrenaline on her part and just pulling with sheer force on his left arm that she'd managed to free. She managed to deliver him, but obviously he was stillborn. The paediatricians, the neonatal team, were there on hand and resuscitated him. He required CPR and adrenaline to restore his heartbeat. He spent a very difficult 6 weeks in special care baby unit. He was initially had his lungs ventilated. He suffered with seizures due to hypoxic encephalopathy. He had trauma to his head, face, neck. He still has forceps scars on his cheek to this day. He was 21. He was diagnosed immediately with left Erb's palsy on the arm that she pulled, and at 3 months of age, he was diagnosed with Erb's palsy. And obviously, I was as well in a very poor way, physically and mentally. But I just, every day, thank God we survived. Maybe it was to change the law, who knows, looking back, or maybe it was to share our story and to help it supports patients making decisions now. So afterwards, despite a very basic explanation of what had happened, no answers were really given as to why it happened or could it have been predicted or prevented. And my sister then was a junior doctor in anaesthetics, and she helped me research. And with her training, she told me that doctors had a duty to fully consent patients, discuss options, and inform them of significant risks. And that supported me finding answers as to why that hadn't happened in my case. And we researched what the risk of shoulder dystocia was in diabetics. And we were absolutely shocked to find out that as a type 1 diabetic, you have a 9 to 10% of the baby's shoulders becoming stuck. And we looked at the GMC guidelines, obstetrics guidelines too, and at that point it became clear that my care with regards to explanations of risks, options for my delivery, and if had been well below standard. I was really upset because finding out this 9 to 10% risk as a type 1 diabetic, and that was withheld from me, but adding in the other factors as well. So the Royal College had guidelines on shoulder dystocia, and some of the other risk factors. Number 1 is type 1 diabetes. Some of the other factors were a non-macrosomic baby, which I had. He was on the 95th centile at 36 weeks. A prolonged labour, which I had. Use of oxytocin, again. Use of instrumental delivery, again. I think by the time I got to theatre, it must have been almost inevitable. And that information was withheld from me. I felt that I had given the information that I was entitled to and allowed to be a partner in the decision-making process with regards to my care and the delivery of my child. And it didn't seem right that doctors were making decisions for me, but without me, and it still doesn't sit right with me. And after all, we live with the consequences 21 years on. So we composed an initial letter asking, amongst other things, we weren't happy with the management of the labour either, but why I hadn't been informed of the risks and why other options for delivery, such as caesarean section, hadn't been discussed. And we were met with a standard reply from the trust that you get, you know, we've conducted our own investigation, blah, 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 we are sorry for your sad outcome, blah, 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 but we're happy that adequate care was given. And, you know, it's a bit strange, isn't it, you know, marking your own exam papers and a trust investigating what happened under there. You know, just, that doesn't sit right. These need to be independent and reviewed, I think, as well. Maybe that's my next battle. But it didn't seem right that, you know, no one cared, obviously, number one, about what had happened, and no one recognised that there was a deficiency in my care. And my concern was that if no one recognised there was a deficiency, that no positive changes would be made. And if no positive changes were going to be made, then surely it follows that this would happen again. So my goal became quickly to make sure that no other patient went through what I did, and that the right discussions should be taking place between doctors and patients regarding options and risks, making their decisions, supporting the patient to make the decisions together. So growing up, Sam needed a lot of care. He needed physiotherapy, occupational therapy, speech therapy. Really horrible, maybe first 4 or 5 years were really, really difficult. My mum was a GP, she retired early to help me. And it was sad because, you know, I would see him and compare him to other children, maybe what he should be doing and he couldn't do. He needed to be taught everything, how to eat, how to walk. Nothing came easy for him. He's now doing so well. He's at university, going into his final year studying software engineering. And I'm just so proud of all the obstacles he's overcome, but it just saddens me because it didn't need to happen. This did not need to happen. What was the point of me attending all these clinic appointments that, you know, for this fancy clinic, if, you know, that what was going to happen was going to happen anyway, regardless. So, not happy with the trust's response, I went to my solicitor not long after he was born, and our case didn't come to the Scottish Outer House until 2009. That's our civil court in Scotland. And we then appealed and we went to the Inner House 3 years later, but they all upheld the decisions, said that the doctors should be assessed by their peers as to which risks to disclose to a patient. And they did accept the 9 to 10% risk was high, but that they focused on the 0.1% of any harm. But that's the whole point of shoulder dystocia. My argument was always been, you know, a consultant obstetrician will tell you, or midwives as well, that deal with this. You can't tell, you can't look at a person and say that's the one that's going to have the really horrendous shoulder dystocia. You can't predict it, can't know until it's happened. Can it be easily managed, or it's going to be horrendous myself? So on we ploughed to this court in 2014, and that's when I met James, who's coming to speak next. And we had a superb legal team, Lawrence and Colin McCauley at that time, and James Baden, and they assembled a bench of 7 judges. And I think that was the first time that I realised somebody was listening. You know, you feel like you're banging on a drum for many years about consent and this what should be happening, but you feel quite isolated and alone. You're a bit mad. But this was the first time that I thought, great, people are listening. So even if we're not successful, I know that I've raised the topic and people are discussing it. Also, the GMC intervened and they turned up at the Supreme Court highlighting the good medical practice guidelines from the era of Sam's birth, and they emphasised the need for doctors and patients to be making their decisions together. So a year later, in 2015, when Sam was 16, all 7 judges unanimously agreed, and the ethical guidance with respect to informed consent that was actually only essential for doctors anyway, but was now passed into law. And Lord Reid, the Scottish judge, stated, the doctors therefore under a duty to take a reasonable care to ensure that the patient is aware of any material risks involved in any recommended treatment and of any reasonable alternatives. And the Supreme Court added as well, with the advent of the Human Rights Act, patients are now viewed as persons holding rights rather than just passive recipients of the care of the medical profession. And times have changed with this, and support groups. But the words that meant the most to me were the words of Lady Hale. And she talked a lot about, you know, what my doctor had said under evidence about it's not in maternal interest for women to have caesarean sections. You know, do we want to be giving, you know, women caesarean sections? We don't think that's a good idea. And Lady Hale said that whatever she had in mind when she said that, this doesn't look like a purely medical judgment. It looks like a judgment that vaginal deliveries is something morally prejudiced as a serious section, so much so that it justifies depriving women of the information needed to make a choice. And I think that's what Montgomery is all about. It's all about choice. So, just to sum up, obviously, despite the horrendous events that we went through, I still have so much respect for the NHS, and it's just an amazing institution with doctors and nurses, all the staff delivering such amazing, excellent, high quality care. And I know, from a sister in anaesthetics, that's often led the way, but also when it comes to supported decision making, informed consent, there's other fantastic initiatives going around in the UK, such as the I Decide consent tool, which I think Maria's going to talk about later, realistic medicine, and choosing wisely. And that really, brings so much joy that patients are being included now. And I think paternalism for too long has been the dominant model for the relationship between the doctor and the patient. It's the idea that this paternalistic model somehow it serves the patient's best interest because we're not quite capable of making our decisions ourselves, don't know what's best for us. And I think at the moment we took that back. I think that, patients are capable of making their decisions and we need the support of our doctors to do that. Thank you very much for listening. Thank you for having me.
Thanks so much, Nadine, for sharing your patient's perspective, and it's certainly lovely for us to to see the human face behind this really landmark decision that really obviously put a face to the name, but also a human story about you and your family, and in particular your son. So thank you for sharing that. And I think the long, hard-fought battle that you've done over the years has really empowered families, etc., in maternity care. So thank you, and it's really changed the landscape quite rightly. So thank you. So we're going to move on to our second speaker. I have the pleasure of for James, who will speak next, and will talk to us about consent from a legal perspective and provide some practical guidance around consent. So for those that don't know James, he's specialised in medical negligence and medical law and professional discipline for over 25 years, and he's been quite at the forefront of some major cases in the House of Lords, Privy Council, Court of Appeal, High Court, and many others in respect of medical law and medical negligence. And he's acted for both sides, claimants and defendants, and of course he was the counsel on Nadine's case. So I'm going to hand over to James now, who will talk to you about the legal perspective and hopefully, I know he will, provide some practical guidance around consent, which I think you'll find most helpful.
Thanks for that introduction. I should say 25 is an understatement. I've been a barrister for 50 plus years and did medical law really almost exclusively for over 35 of those years. I apologise for my disguise. I'm sheltering because I'm so old and I can't be bothered to shave. You've been lucky, I think, if I may say so, to hear from the heroine of the Montgomery decision, which is Nadine herself. And the facts of her case, I think you may feel, were both chilling and also instructive. And I shall run through that quickly in a moment, if I may. I will speak quickly. I do apologise, but I've got quite a lot I want to cover. Before the Montgomery case, the law of consent relied on what's known as the Boland test. That is to say, the adequacy or otherwise of disclosure of information for the purpose of a woman's consent was judged by a very simple and very basic test. Could there be found at least a body of the medical clinical profession who would support, endorse or sanction what the doctor in question chose to do or not to do? If such a body could be found, the Boland test says there can be no possibility of negligence, even if that body is a tiny minority of the profession with whom the vast majority would strongly disagree. The effect was, of course, to make the profession judge in its own cause. So, as you will all be aware, I'm sure, there were, or still are perhaps, as many opinions about what should be told to a woman in her pregnancy and in her labour as there are clinicians. And indeed, there are still some dinosaurs who strongly believe you should tell a woman nothing because all it does is frighten her poor little head and she won't be able to understand it anyway. That principle was possibly defensible in relation to doctors' decisions about diagnosis and treatment. After all, they are based on the doctor's own skills, learning and experience. They're decisions the doctor himself makes. It was not defensible, and never was, for the question of whether adequate disclosure of information had been given, because consent, which is legally essential in law, is the patient's decision solely to make, based on what the patient decides about the risks and benefits and what he or she wants to do with her own body. And thus the presence of a body of professionals who would agree that the information given was adequate was not a fair test at all. This is a point which I'd argued for years and was regarded as a heretic. But it was perfectly plain to me that the real issue was whether a patient had been given sufficient information to make a real choice about whether to consent to what is proposed and whether to submit her body to what the doctors were saying they were going to do. And there were many cases in the old days, just very simple ones, when a patient told me the doctor arrived at his bedside one morning and said, "Good morning, George, we're going to cut your leg off today," without a word of explanation, consultation, or discussion. That's the sort of thing which in the old days certainly happened quite a lot, and it represented the condescending, patronizing view that clinical professionals used to have in respect of a patient's ability to understand, a patient's ability to make a sensible decision. And when I emphasize to you the difference the modern law makes to that, I should tell you this, that it is our perfect autonomous right to decide what shall be done with our own bodies. And what is more, it is our perfect autonomous right, provided we're of sound mind and adult years, even to refuse treatment which is essential to save our own lives, because we don't have to submit to it unless we choose on proper information to do so. And Nadine is the heroine of this case, and I want to just briefly tell you why her case is both chilling and instructive in respect of consent law. But before I do, I'd remind you all that when the Montgomery case came to the Supreme Court, the judges unanimously decided that the old law, that the Boland test, which I've just described, should govern whether the information given was adequate, should be removed altogether from the issue of whether sufficient information was given and whether there was therefore a valid consent. They found, as I've argued for years and years, that it has no place whatsoever in the patient's own decision whether to consent or not, which must be a free choice, and it isn't a real choice at all unless it's based on adequate information, as I'm sure you'd all agree. And the simple change was this. The Montgomery test for the adequacy or otherwise of disclosure of information for the purpose of obtaining a valid patient consent ordains that the doctor's or clinician's duty, midwife's duty, all the clinicians are involved, the duty is to take reasonable care to ensure that the patient is aware of any material risk of proposed treatment or of any reasonable alternative or variant treatments. And a material risk is now defined by that decision, which is down to Nadine for having been brave enough to bring her case. What is material is defined as follows: a risk that a reasonable person in the patient's position would be likely to attach significance to. That's an objective test. Would a reasonable person expect to be told X, Y, or Z? Or B, a risk that the doctor is or should reasonably be aware that the particular patient would be likely to attach significance to. Because that's a subjective test, the patient has particular characteristics, personalities, histories, obligations, and so on, that makes a particular piece of information of special importance to that person. And just to give a very simple and utterly basic example, if you're doing an operation on the hand of a concert pianist who makes his living out of playing the piano, and there was a minute risk that one of his fingers might end up paralyzed, for him, that minute risk might be of the utmost importance. Whereas for you and me and the rest of us, we just say, I'm not very bothered by this tiny, tiny risk. Just hope it doesn't happen. So just let me run through quickly. I know I'm speaking very quickly. You'll have to forgive me. And some of the points I want to make to you about the new law. Before I do, I've had circulated to you a document which I think I called Practical Guidance or Practical Tips for Clinicians in Giving of Consent. I hope that's helpful to you all. It stood the test of time. It's been used, in fact, all around the world, and I've adapted it as time went by to reflect the cases that have come along. It looks as if it's a great long document, but actually most of it is trying to explain what the law really means and how you should go about applying it. And the other document, which is, I feel very lucky that it came to my possession. It's an article written by Lauren Sutherland, who was junior counsel at the time in the Montgomery case in the Supreme Court. She's a very excellent lady. She's a Scottish barrister. She was the junior in the case, and she was the one who took Nadine through those awful experiences in Scotland when the judges entirely failed to apply sensible or fair-minded principles and ignored even the law as it existed in the old days and made outrageous decisions, both at the trial and on appeal, as she's explained. That article covers a case called NKX, which discusses a dreadful event concerning VBAC, vaginal birth after cesarean section, and it contains an awful lot of wisdom and advice about the way in which we should all expect obstetricians and midwives to go about their job when dealing with, in that case, a problem case where the woman was having VBAC. So let me just run through a few points which show why Nadine's own case is both chilling and instructive. Firstly, as I've explained, because it evidenced the patronizing and condescending attitudes of the one particular obstetrician who represented quite a proportion of the profession before the Montgomery case was decided, namely that proportion who thought it quite unnecessary and a waste of their time to discuss or to raise with the patient the risks, the benefits, the alternative options, which any reasonably intelligent person, you would think from the position of the patient, would want and need to know before agreeing to the course of action that was proposed. Secondly, in her case, the increasing size of her known macrosomic baby was measured on a very regular basis, unusually, as you heard, every fortnight, but the obstetrician curtailed those measurements before the due date because she thought it was only frightening the mother. It should have frightened the obstetrician, of course, but it appears it didn't. And that measurement was curtailed without discussion or explanation. Thirdly, because labour was then induced in this high-risk case in a known macrosomic fetus in a 5-foot-tall, insulin-dependent diabetic mother with no consultation or discussion of the risks. Induction, in other words, was imposed upon her with no real consent at all because she didn't know what was involved in risk and benefits. Fourthly, because the option of elective section in this case was altogether denied to her, withheld. And McLennan, the guilty obstetrician, said that she did not offer caesarean section because Nadine would have accepted it. And in her opinion, McLennan's opinion, caesarean section was, as she put it, not in the maternal interest. Fifthly, it's chilling and instructive because intervention by section was promised if things should go wrong in labour, without reference, of course, to the simple fact that once shoulder dystocia has occurred, which was the big risk in this case, caesarean section would be impossible to carry out. Although there is a manoeuvre called the Zeffirelli manoeuvre, I understand, which in the third world is sometimes used when they push the baby back up into the uterus, or try to. Sixthly, it's chilling and instructive because when labour became prolonged, arrested or obstructed, as it was predictably likely to do, without any discussion or consultation with the mother, they did not go to section at that point. Instead, they pumped syntocinon into her, the augmenting of the contractions being the desire, to force the baby down the birth canal, again without discussion, consultation or explanation of risks and benefits. Eighthly, because the outcome of all this was, of course, a catastrophe for Sam, although he's beaten all the odds and has done so very well, as Nadine has just told us. So you will know that macrosomia, particularly in a very small mother such as this, carries a genuine and real risk of shoulder dystocia. About 1 in 9 or 1 in 10 cases, if they're allowed to labour, will meet the shoulder dystocia. But as Nadine said, of those 10%, it appears that about 1% of the 10% will suffer very serious harm or potentially very serious harm because of delayed and difficult freeing of the shoulder, with brachial plexus lesion being common in those disastrous cases, but sometimes severe asphyxial brain damage and even death of the baby. These were small risks, but you may think risks of which any sensible mother would want to know before deciding whether to consent to induction, whether to consent to augmentation of a labour that seemed to have got delayed and obstructed or arrested, and before making any decisions about whether or not she wanted to labour or would rather go for elective caesarean section. Interesting, McLennan, the guilty obstetrician who still proudly practices in Scotland, explained that in her opinion, shoulder dystocia was not a great problem because it was nearly always overcome without the mother even being aware that it's happened. Well, I've seen clear evidence of what actually happens in shoulder dystocia. The room fills up with all the experts, the consultants are called in, paediatricians are called in, the woman is pulled to the edge of the bed, her knees are pushed back on her chest. All sorts of extraordinary things happen to her in a frantic and emergency situation of which no woman could be unaware, as poor old McLennan claimed. And it appeared to me, must be true, McLennan had never encountered it in her life. So induction was imposed on this mother. And the central principle of the old law was that she was defensible because, in her opinion, it wasn't necessary to give the mother any information. And that was supported, would you believe, by defence obstetric expert witnesses in Scotland. And the way they defended it was completely outrageous in every respect. The case was, in fact, indefensible, as the Supreme Court decided. And the irony of all this is this: the defending barristers defended this case to the hilt when it had no defence. The consequence was the old law of consent ended up being thrown out of the window and the new law brought in, exactly contrary to their own clients' wishes, because of course they acted for the hospital board. And if they'd done the sensible thing and told their clients there was no defence, this is only about how much the damages should be, it would never have come to Supreme Court, and the law would still be as the old law is, to the great satisfaction of their paying clients, the hospital boards all across the country. I should tell you that in the old law, Sidaway's case, Sidaway being decided as long ago as 1985, Lord Diplock gave the leading judgment, and he said this: the only effect that mention of risks can have on a patient's mind, if it has any at all, can be in the direction of deterring the patient from undergoing the treatment which, in the expert opinion of the doctor, it's in the patient's interest to undergo. So there was encapsulated the old-fashioned, condescending, patronizing view. The consenting was ready for the doctor to decide, should you or should you not have this treatment? I, the doctor, will decide. And the only way information could affect the patient was to frighten them and deter them from having treatment which the doctor knew was right. You might be amused to know that Lord Diplock, a law lord or Supreme Court justice to whose opinions I never turn for enlightenment on any subject, also said, interestingly, that in the case of a judge like himself, with the advantages of education and training that he had, he would personally, in his judgment he said this, expect to be given all the information so that he could make a reasonable free choice about whether to consent. So there was one law in his opinion, the law lord, the Supreme Court judge in 85, for judges like him, but for all the rest of us, the great unwashed, all the rest of us, there was no right to have information which the doctors didn't think fit to give us. Well, let me turn quickly from that, and I know I'm rushing, but I hope you'll forgive me. There is no doubt that midwifery and obstetrics poses particular challenges for the professionals who must apply the new principles of the consent treatment. And first among these is the fact that, in contrast to other clinical fields of work, your patients are happily, in most instances, not ill. And it follows from the reality of this that the management of pregnancy, labour and delivery, in most cases, doesn't involve a great deal of what in other clinical fields is known as treatment, as that term is ordinarily understood, but rather helping and supporting what is a natural and often spontaneous process. And that is, to a large extent, compared to surgery, for example, non-interventional. You don't do a lot of things to the mother which she might want to decide whether to submit to or not. And what is more, there is, in the majority of cases, no serious alternative to proceeding through labour to delivery. The baby has to come out. The mother can't refuse to go ahead with it because she doesn't like the idea. She can't say, I've changed my mind, I'm going to get a puppy instead. So the fact is, what happens has to happen in one way or another. But there are interventions which are inevitable and very important in every such case. The first and obvious one is the vaginal examination. And in particular, for the first-time mothers, but for all mothers, it's essential that that process is explained and consent obtained. I think possibly a blanket consent at the beginning should suffice for the further and sequential VEs that follow. There are risks of repeated VEs, as you will all know. So it may be that at the beginning, when you first seek consent to them, you explain that you try not to do too many of them for the reasons you can explain. And then if the time comes when you do have to increase the frequency and the number of them, you will have explained, and you will explain again why you're doing that, whereas normally you would try and avoid it. Simple things like abdominal palpation is a form of touching, and touching is, in our law, illegal unless the person touched consents to it. So putting it bluntly, even that, for its very valid clinical purpose, should be the subject of informed consent from the mother. Nowadays, I'm told that women, young women, pregnant women, are much less sensitive about such things. In the old days, they were often much more sensitive, women who were extremely concerned about any form of touching other than by their own loved ones. So again, an enduring consent to palpation of the abdomen may be sensible at the beginning, which should carry you throughout, but don't ignore it, don't forget it. Then there's the CTG placement, which is a commonplace thing. You will know that when you place that, you're having to put the monitor over the mother's abdomen. Again, it's a form of touching and a sort of intervention with her, and you do need to take her consent, which would involve, I think, explaining what it does, how it does it, and why the monitor is needed. Those are all straightforward things. What about students or observers? Well, it is important that if they're wanting to witness labour and delivery, that the woman's consent is obtained. It's a very intimate process, as all of us know, and the need for students to see these things should be the subject of sensitive explanation and a polite request. And of course, the mother is entitled to refuse. My wife worked years ago in St. Thomas's, where we had all our babies. So when she came to have them there, she said she didn't want medical students present, which is perfectly reasonable, I think. But when the time came that two who'd not seen 5 normal births and needed to, the doctor said, could they come in? She was now in the throes of what turned out to be a very successful normal labour. And I remember her saying, you can bring the London Fire Brigade in if you want to, I don't care. So that by that time, she was perfectly happy for them to come in. But was she really? Which brings me to an important point about intervention with mothers during labour. Consent has to be a rational and free choice. And there is a great concern that when a woman is in the throes of perhaps a very painful and worrying and alarming process of labour, especially for first-time mothers, that there will come a time during that process when she is not in the calmest, most rational frame of mind. That's not meant to be a demeaning or condescending observation by a mere male like me. But as you gathered, I've sat through 3 births with my wife and our kids, now all grown up with kids of their own. And I think we all know that there comes a point in labour when the mother isn't necessarily thinking very clearly about peripheral things, but is focused entirely on the process of her body and what's happening to it. So don't forget that, if possible, as the NKX article by Lauren Sutherland explains, the guidance in every respect is to try and get these sort of issues discussed in advance of labour and delivery. There are, of course, a number of interventions for which you all are responsible at different times during your management of childbirth. To list them, I mean, I'll run through them quickly because I'm teaching my grandfathers to suck eggs, but membrane sweep, amniotomy ARM, pain relief of different kinds, including epidural, manual cephalic rotation for malposition, external cephalic version for breech, whether that's much practiced anymore, I don't know, induction by vaginal pessaries, the administration purpose and effects of augmenting drugs, syntocinon, as in Nadine's case, the McRoberts manoeuvre if a woman has, after full information, decided she wants to go ahead with labour with a macrosomic baby, the McRoberts manoeuvre and how it's done. VBAC, the risks and benefits. Caesarean section. Manoeuvres to relieve fetal distress, for example, when the woman is turned on her side. Let's take that very simple and basic one. All these are interventions for which, in ideal circumstances, unless in an absolute emergency when there's no time for any discussions, you need to have explained to the woman and got her true consent as a rational and free choice. As my practical tips show you, and I won't go through them in detail now, I hope you'll have a look at them in your own time, but in calm prenatal conditions, not diverted by pain or fear, that's the time when ideally these discussions and explanations should take place. Not when things, for example, in an emergency situation, when things have become probably very alarming to the woman who's already in the throes of labour, it also may appear to her rather frantic and hurried because people are doing something as quickly as they can. That is not an ideal circumstance in which to ask a woman to make a rational, clear and free choice. So the golden rule then is, so far as possible, to ensure discussion in advance of possible complications where you think it's necessary, but also especially where in this woman's case a complication may be more likely to occur than others. VBAC is a classic example, and a macrosomic baby with a woman determined to try labour and delivery. I said that Nadine's case was instructive, and what I think would help if I just ran through what they should have done and didn't do any of in her case. 1, explain the special risks of a macrosomic baby in a woman of small stature like her and the risks of shoulder dystocia. 2, to give clear information about what shoulder dystocia meant, what it entailed and the risks it presented, and of the options to avoid that risk. Thirdly, to spell out the option of elective caesarean section in advance of labour and in place of labour, with a brief account of the disadvantages that some people perceive of caesarean section, the short-term effects on the mother after section of inability to lift, carry, drive, and manage her other children as freely as she would like, these sort of things, but of course the information about the grave danger of shoulder dystocia to her and her baby. Remember, Dr. McLennan, the obstetrician in this case, Nadine's case, said that she didn't offer a section because she did not consider it to be in the maternal interest. Make of that what you wish. Next, if the mother is doubtful or uncertain about elective caesarean section, it would be necessary in a case like Nadine's, of course, to give an account of what the shoulder dystocia manoeuvres and so on would involve, and the need for forceful extraction, which might occur with the risks of brachial plexus lesion, asphyxiation, or even death. Just let me pause there a minute. In England, not Scotland, I have met many obstetricians and midwives since that case was decided. I've talked in hospitals and lecture halls and colleges, you name it, about all this. And I have found it unanimity among the English professionals that they would not only have offered elective caesarean section to Nadine, but they would have strongly recommended it. And that possibly may find agreement with many of you. So it makes it all the more deplorable that in Scotland it was not mentioned or offered to a woman who was plainly frightened, as she's told you herself, and that McLennan knew she was frightened about whether she could actually manage to deliver this very large baby vaginally, given that she had her own very small stature. Not that stature always correlates to pelvic capacity, I know, but nevertheless, she should have been offered it. There is no doubt in my mind at all. Secondly, of course, in respect of Nadine herself, in that regard, induction was imposed upon her, as I've said, literally imposed on her without any choice. So there was no true consent to it. And induction should have been explained in detail. If she had been determined to go ahead with a labour, which she wasn't, if she'd been given the choice, the fact that the pessaries once inserted give a dose of the, of the inducing drug which can't then be titrated. You can't affect the amount it's delivering or what its effects are on the woman. And we know that some women end up with tetanic contractions when they're induced. And there are other features of induction which should have been talked through with her. So syntocinon should have been the subject of a discussion and explanation. Obviously, it augments the contractions, and that drug itself can lead to problems, although it has, of course, a very important function in the attempt to achieve a successful vaginal delivery in Nadine's type of case, if she had been determined to go ahead with it. So at every step, everything was done wrongly in Nadine's case, absolutely everything. And yet the case was defended on every front. When I tell you, which I was mentioning earlier in our discussions with the team behind this seminar, didn't offer it to Nadine because Nadine would have accepted it and she didn't consider it in the maternal interest. Nadine's own expert witnesses said, of course, she'd accepted it if she'd been offered it. It's what she wanted because she was frightened, and women do accept it. Wait for it now. The defendant's own expert said that if offered it, she'd have accepted it. Even the defendant's expert said that because women do accept it when they're confronted with the risks of shoulder dystocia, etc. The defendant's barristers in this case of Nadine argued in court that if offered it, she'd have refused it. And the trial judge said, quite right, she'd have refused it. And the 3 appeal court judges said, quite right, she'd have refused it. Breaking, as I've just said to this team before we began the seminar, the 2 major rules of judging. 1, decide the case only on the evidence before you. And 2, don't decide the case exactly contrary to all the evidence before you. And that's what those Scottish judges did. They broke both those fundamental rules of judging. So let me just give 1 or 2 ideas for how this proper consenting process can be achieved. The big problems, of course, are, the main problem is time, isn't it? Time and recording of conversations, discussions, and consenting information given. The article by Lauren Sutherland, NKX, which you all have, I hope, is extremely useful in this regard. It talks about how it's important to have what Nadine prefers to call supported decision-making. The medical professional bodies seem to call it shared decision-making, which possibly falls, as Nadine would think, into the trap of the old law. It isn't shared, actually. It's the woman's decision to make. She makes it, and therefore supported decision-making is probably by far the better way of thinking of it. Try and find time at the different antenatal visits to talk about the various interventions, some of them very straightforward and ordinary, others not, the possible complications and the responses to them, the options that the mother has for the way to deliver her baby, and in particular, options which may have to be taken if things don't go swimmingly and according to plan. All those things should be discussed, if possible, in advance, and especially with someone like Nadine, any special risks which her case gives rise to, which is obvious in her case, as I've rather at length gone on about, I'm afraid. Time is difficult. One suggestion which oddly came from Bertie Lee of the Medical Defence Union, not a strong fan of the Montgomery decision, I can tell you. His idea was that perhaps there should be an extension of the cooperation card, which the pregnant woman carries with her as she goes to each antenatal visit, with a provision on the card for mention of the discussions about consenting and the information given, so that you would have a sort of running cumulative record of what's been discussed with her and what she's agreed to or doesn't want or does want along the way. So although it wouldn't all necessarily be discussed at one fell swoop, you can have a record of when you discussed different aspects of it as you went along. That might be a very helpful way, I think, of making a decent record of what's happened. The NKX case and the guidance from the Royal Colleges makes it absolutely clear that you should make notes about what is discussed and what the woman's views were at the time or as soon after as possible. I think there are many difficulties with all your time being so short. I do know that, but they also emphasize a very important point. The notes and records you keep are not just to protect yourselves from litigation, although they may have an important function in that regard, but they're also to ensure proper continuity of care, so that when different people are seeing the mother, they know what's gone on before, they know what's been said and what the mother's views expressed may have been. Quickly, in case you are among those who are very worried about the effects of the Montgomery decision, it would be very helpful to have checklists prepared, particularly for people undergoing, for example, VBAC or trial of labour in any form or other, or for women who are deciding whether to go for elective section or not. And if you had a checklist where you asked her to read the different points, tick against each, and then sign that she's read it, you might find that you covered everything you needed covering and didn't risk forgetting things because you were in a hurry because you had too much work on your plate. I think I'd like to offer you a little comfort about litigation about consent cases. Yes, the litigation would now involve an interesting discussion about whether or not what you disclosed to the mother when asking for her consent was sufficed in the new law, i.e., was it material risk, was all material risks put before her? And it may be that in some instances judges will find that you did not put adequate information to get a valid consent. But that case won't be won by the mother unless she proves also what we call causation. She doesn't have to prove only that she wasn't given adequate information. That in itself won't produce a finding against you or a damages claim, because she has also to prove that if she had been given the right and full and adequate information, she would have refused the given intervention or treatment which had a bad outcome. And that's very difficult to prove if what was done was obviously in the face, prospectively looking forwards, sensible, right, rational, and normal to do. Remember, the judges are very conscious that when things do go wrong, when a choice has been made, perhaps without adequate information, there's a lot of hindsight involved in the complaints made against the clinicians. And the judge has to decide the decision making at the prospective moment before things go wrong. What if she'd been given the proper information then? Would she in fact still have chosen to go ahead with the intervention that was carried through? And in many, many cases, judges decide, yes, the patient would have done, because what was done, albeit without adequate information, was the most sensible, safest, proper course to take in that woman's case. Sadly, it did go wrong, but that's only hindsight. So that's a comfort for those who worry about the consequences of this new law. There are a number of cases that have been decided since Montgomery. In some of them, Scottish judges in particular have been completely incapable of understanding what Montgomery had actually said and the change in the law that it brought about. And that also applied initially to some of the judges in England down south. We have different legal systems, of course. But the fact is that those cases which are very, oh no, I have hardly got time. Have I just to give a very brief account of some of the cases, what they've decided. I'll do it very briefly. I might run over just 2 or 3 minutes, I'm sorry. A case before Montgomery is called Pierce against United Bristol Healthcare Trust. A woman had gone well past term, and the clinician, the obstetrician, persuaded her to wait the onset of natural labour without any mention of the risks of doing so. Sadly, the baby was stillborn, and she sued on the basis that she hadn't really given informed, as it was sometimes called, consent to waiting post-term. And under the old law, she lost, because lots of doctors stepped forward and said, oh, we wouldn't really think it right to worry her little head about the risks of going past term in this particular case. And so under the old law, it was lost. But Lord Wolfe, who was in my chambers and was my pupil master, as we used to call it, now called pupil supervisor, who's been a great, great man in English law, said, even before Montgomery, he said this: it seems to me to be the law that if there is a significant risk which would affect the judgment of a reasonable patient, then in the normal course there is the responsibility of the doctor to inform the patient of that significant risk if the information is needed, so the patient can determine for him or herself what course he or she should adopt. So there, even before Montgomery, was one of the wisest and best judges we've ever had, expressing what Montgomery later said should be and was the English law. In a case called ML, M for mother, L for Lima, against Guy's, if you want to make a note, ML against Guy's and St. Thomas's, a claim was lost again in that case, but Mr. Justice Martin Spencer made this point. He said that it was important in consent cases, particularly in obstetric cases, to be ensuring that the patient was at the time in a fit state to listen, reason, and make informed choices. Not, in other words, in extreme pain, in the throes of a difficult and frightening labour. She should be in a condition where meaningful decisions can be made by her. And that's a very important observation by a judge in a case that was lost after Montgomery, but still he thought it right to say that. In A, capital A, against East Kent, again, you can Google these cases, you made a note of their names, capital A against East Kent, there was a materiality issue. Was a less than 1 in 1,000 risk of chromosomal abnormality one that doctors should tell the mother about? She said, if I'd been told, I would have opted to have the test for that rare abnormality, and it would have turned up the fact that my baby had the chromosomal abnormality, and I would then have aborted the child, who rather instead, without all that information, of course, sadly, was born terribly genetically abnormal. The judge said no, that was what he called a theoretical, negligible, or background level of risk. And that was not one which was material and not one which the doctors had to disclose to this particular mother. Oddly, he said that if risks had been greater, say 1 to 3%, his decision about requirement to disclose it would have been different. Well, maybe you agree or disagree with him. It's up to you, really. But what I would say is this, that Montgomery expressly disapproved deciding whether disclosure should be based on percentage of risks. Percentage alone is not the key. Remember this, to a patient, a 1% risk of extremely serious harm might be very material to a decision, especially if there are alternatives to the treatment proposed which carried less risk, may be of great importance, whereas a very large risk, say 30 or 40% of some very minor complication, would seem very immaterial. Oh, I don't mind running that risk. So percentages alone won't do. A case which you might be interested in called Webster and Burton. Webster, again, I say and, we always say and. That means versus. God knows why we say and for versus, but it should be Webster v. Burton, but we just lawyers say Webster and Burton. I wonder why, I still don't know, but anyway, there it is. In that case, the claim was for a brain-damaged baby who'd sustained a period of hypoxia some 42 to 72 hours before the spontaneous labour occurred. Alleged was mismanagement of the antenatal care. They should have done more to assess poor growth, asymmetry, polyhydramnios. And if that had been done, the findings would have led to hastening of delivery by induction, and the episode of hypoxia would therefore probably have been avoided because it would have been done before that time occurred in this woman's pregnancy. Secondly, it was alleged that they should have told the mother of the risks of waiting for spontaneous labour and advised her of the alternative of early induction. That case was originally decided before Montgomery and was lost, but the appeal, would you forgive me 1 sec? I'll have to just say I can't answer this. Hello, could you ring back? I'm in the middle of a talk. Should have told the mother of this. It was lost before Montgomery, and the appeal that she raised was after Montgomery, and luckily on appeal she won because the law had changed. And what the judges said on appeal was that she should have been told of the risks and uncertainties in her case of waiting, and the alternative should have been offered to her of early induction, and if adequately informed, she would have accepted it. Finally, just quickly on cases, there have been a number of cases where the mother says, if I'd been made aware of the risks here, I would have wanted elective cesarean section. And judges have found that quite difficult because they know hindsight has affected the woman's thinking a lot when things turned out to go wrong. And they looked for special features. A midwife who'd seen a lot of disastrous cases was believed when she said, I would have accepted, would have wanted section. A woman whose own sister had had a catastrophe during natural childbirth was held to have good grounds for being believed when she said, I would have opted for cesarean section. There may be special features in given cases why that is so. I know I've hurried, I'm so sorry. I apologise if I've gabbled, but I hope that's been helpful, and the documents I've supplied for you are also instructive. Thanks.
Thank you very much, James, for that, as ever, insightful and very dynamic talk, particularly on covering the legal perspectives. But I think was really helpful for us all is putting the context behind Nadine's case and how that decision was reached in the Supreme Court. And also, thank you very much. I know it's taken time for you to share your practical tips on consent, but I'm sure that all the healthcare professionals who are on the webinar will find that extremely valuable. So thank you very much, James. Now we've gone slightly over, but we'll obviously, try and extend the live event. So we're going to have a short comfort break now, and I'm going to suggest we probably return about 11:15, and then we'll move into the second half of the webinar. Just a reminder for you all to submit your questions to the question answering function on your screen, and then we can answer them at the end of the panel discussion. We've got some coming through, so that's great, but the more you can send through, that'll be fantastic. So hopefully everyone can go off now, have a quick comfort break, get a glass of water, and we'll hopefully see you back here about 11:15. Thank you.
Sorry, I overshot a bit. I didn't matter too much.
Welcome back, everyone. I'm Anne Kavanagh. I'm a Senior Associate in the London office, and a little bit of background, like Julianne, who's hosting this webinar, we are for former nurses. So moving on, we have a slight change to the running order for the remainder of the webinar. We're going to hear next from Maria Booker, who is the Programmes Director at Birthrights, where she leads Birthrights Policy and Legal Hub, and also manages their training for healthcare professionals and peer supporters. Maria's background is in project management and policy within the maternity sphere, and she was previously UK General Manager of Maternity Neighbourhood, a US-based midwife-led company developing a woman-centred electronic maternity record. This may have informed her work on the Ida Side tool for maternity care, which she will now speak to us about. Over to you, Maria.
As Anne said, my name is Maria Booker and I'm Programmes Director of the charity Birthrights. Have the next slide, please. For anybody who's not familiar with Birthrights, we're a charity that's dedicated to improving maternity care through a focus on human rights. We were founded in 2013 by a human rights barrister, and it's a delight this morning to follow Nadine Montgomery in particular, who we're very honoured to have as our patron at Birthrights, because the Montgomery versus Lanarkshire case is so fundamental to our work, and we owe a huge debt of gratitude to Nadine for laying the foundations for a lot of the work that we do currently. Next slide, please. So I'm going to talk mainly about Ida Side, the tool that we're working on with NHS England and a really wide range of partners. But I just wanted to situate that in the context of what we're trying to achieve, which is really about cultural change. And I just wanted to show you this quote from Lauren Sutherland, James's esteemed colleague, who he's already mentioned. But I think this is a really good summary about what Montgomery is about and why it's so important. We tend to think of Montgomery versus Lanarkshire as a case about consent because of its importance in changing the test for consent in the courts. But fundamentally, it's a case about the right to choose. And the work that we do at Birthrights based on this case is really about trying to change the culture in maternity services, so that the GMC guidance that has been in place for so long now is the norm for women, where women know that they have the right to make the decisions, and healthcare professionals are comfortable with their role in advising women, giving them the best evidence-based and up-to-date relevant information, but recognising that the decision is with the woman herself. Next slide, please. So I just wanted to start with a point about language, because if we're about culture change, the language we use is really important. And this sort of process where we lead up to a consent decision is often talked about as shared decision making. And James has already said that it's not shared at all. And I just wanted to share this slide, which illustrates the point, I think, about why that language can be problematic. So this is a slide that's taken from a e-learning module that's been developed with the Royal College of Obstetricians and Gynecologists and the Winton Centre for Risk at Cambridge University. Now, the module itself is brilliant. It gives obstetricians lots of good skills about how to have these choice conversations in practice. But if we just look at the language used here, it says shared decision making is the process of bringing evidence into the consultation and incorporating it into a discussion about the patient's values and preferences. And then further down it says shared decision making is a hallmark of good clinical practice, which of course it is, and a way of engaging patient engagement and activation. And I don't know about you, but I don't read that slide and come away with a strong impression that this is about healthcare professionals supporting women to make the informed choice that's right for them. And I think that's what can be problematic about the language of shared decision making. Can I have the next slide, please? We've just got a new puppy recently, a 9-week-old puppy. So we've had a lot of this sort of game recently, a bit of tug and war. And when I think of the term shared decision making, this is the sort of image that springs to mind. I think there are sometimes elements of the healthcare professional body that are really willing to engage, happy to have that conversation, happy to share the conversation, but there's a bit of a reluctance to give up control. And that's why I think we need to use terms like supported decision making, which is our preferred term. And within the iDecide tool, we've, after a lot of wrangling, agreed on the term informed decision making. But I think the important thing is it's not shared decision making. The woman is always the decision maker in maternity services. Have the next slide, please. So how are we doing in terms of implementing Montgomery versus Lanarkshire in practice, and why is it important? This slide sets out some of the key takeaway points from a research study that was published by Jackie Nichols and her team at UCL in summer last year. And the study was an ethnographic study, so it looked at about 20 women and looked at their experiences of appointments in the antenatal period, and looked at whether what was said in the judgment in Montgomery versus Lanarkshire was actually reflected in practice. And what it found was that there's still some way to go. One of the main conclusions was that pregnant women don't always experience consent as a choice. There's a culture of expected compliance. And I think that phrase is really telling about the culture of maternity services, and it's an indicator of the journey we still need to go on, really, to get to a point where everybody understands who the decision maker is in maternity services. The study also found that the context of disclosure, so the relationship that the woman had with the healthcare professionals, was really important. So women who had continuity of care, who trusted the healthcare professional that they were with, perhaps actually asked less questions because they were more confident in what they were hearing. And the conclusion was that it was the sense of control that was really important, and the amount of information given was less important. It was more about getting the information that was specific to them, and having that relationship with the healthcare professional, so there was that trust there. The study also found that healthcare professionals often found it hard to give individualised information, which I think is a really important point that we need to take on board. and also that there's still some way to go in terms of doctors, but particularly midwives, awareness of Montgomery and its implications in maternity care. Next slide, please. In addition, we ran a survey with Mumsnet earlier this year. We actually ran it over the Christmas period with a view to publishing it in March, but the pandemic delayed that a bit. But the survey had 1,145 respondents, and it asked a number of questions about how they found the information giving process during the antenatal period and whether they felt they were in control of decisions and were given choices. And one of the questions set out the legal reality as stated in the Montgomery decision, which is an expectant mother is the primary decision maker about her care, and the midwife and doctor's role is to advise her. And the survey asked if that's how women had experienced their care. And worryingly, less than half, 45% said that that was a reflection of their care, and 42% said it definitely wasn't a reflection of their care. So I think that shows kind of where we are and the journey that we still need to go on in terms of changing the culture of maternity services. Have the next slide, please. So with that in mind, I just wanted to give you a bit of the history of where I Decide has come from. Next slide, please. So Birthrights held a seminar back in October 2017 in Oxford, where we brought together some healthcare leaders, some philosophers, some lawyers, and what we wanted to grapple with were the challenges and opportunities of the Montgomery decision. And there were three main outcomes that came out of that seminar. Click forward, please. The first one was that there needed to be training for midwives and doctors, not only about the legal context and the reasons why we need to give women these choices and support them to make choices that are right for them, but also about how to do that in practice. And the second outcome from that seminar was that we also needed to raise awareness amongst women and their families that they have the right to choose, so that they can actively engage with that process too. Next slide, please. But the third outcome of that seminar was the idea for a decision-making consent tool. So people at the seminar sat around and said, what if we had a tool that gave healthcare professionals and individuals giving birth a common framework where it was clear what the decision was that had to be made, it was clear what the reasonable options were that could be discussed. It would give the opportunity to put forward evidenced information and to have a dialogue about that information. The decision would be recorded, and then that whole process could be evaluated. And what if that tool could work even in labour, which is the most challenging situation for healthcare professionals to feel that they've gained consent, as James has covered in his talk earlier. Because if it worked in labour, then it could work in any other scenario too. Next slide, please. So as a result of that, there was a follow-up workshop about 6 months later in April 2018 with all the people present who were on the slide. And that was really where I Decide was born, if you like. That workshop came up with a straw person and some principles that would drive this tool. And the principles were that the material facts needed to be presented and considered. It needed to give opportunity for the woman's personal views to be considered and heard as well. It needed to give the space for opportunity for clarification and for discussion and dialogue to ensure that the woman really was in a place where she could take this decision and felt informed and able to do so. It needed to ensure that the woman was clear that the decision was her responsibility, but that her autonomy was also respected. And it needed to enable the documentation of that decision-making process. Next slide, please. So this is the outline for I Decide, the tool. It's really, at its heart, it's quite a simple framework, but it helps both healthcare professionals and women feel confident that the consent process has been gone through thoroughly, everybody's had the opportunity to express their views and to consider all the relevant information, and that everybody's on the same page. So the tool starts with a discussion about how urgent the decision is, the immediacy. So if you've got 10 minutes to make this decision, this process will be quite curtailed, it might be quite concise, it might look quite different to a decision where you've got a couple of hours to make it, or even longer. It then starts with the details of the current situation. So what's happening now? What decision needs to be made? For example, a woman might find that her labour is not progressing as well as everybody would like. There might be the option to go for an instrumental birth or a caesarean birth, for example. There would then be an exchange of information about what's been discussed in the past, how the woman feels about it, any other additional information that's come to light. So, for example, the woman might have said in her birth plan, really not keen on any instrumental delivery. So that's a relevant factor to take into account. The healthcare professional and the woman would then look at all the individual choices that are on offer. What are the different options? So if that's instrumental birth or caesarean, or leaving it, waiting for a bit, might be the reasonable options in that scenario. And you could use a tool like Brain, benefits, risks, alternatives, what's your intuition saying, and not now, to discuss those options in more detail. There would then be an explicit opportunity for the woman to confirm her understanding, to ask any questions, and before she makes the decision. And then finally, sometime later, the woman would be sent a survey, quick text, a few questions to evaluate this process, so that healthcare professionals can learn from their experience and improve at this process. Next slide, please. So where have we got to so far? So last year, Lisa Ramsey, who's the project lead at NHS England, and myself went to do some testing with staff and families at two hospitals, one Queen's in Essex and Liverpool Women's, to say it feels a long time since it was possible to be in a room with women and families like that. But they were really great sessions, got some fantastic feedback, which I'll go through in a minute. Following the testing sessions, a national steering group was formed. So that involves service user reps, the Royal Colleges, NHS England, and a number of other interested parties to make sure that we've got all the right people around the table and everybody's views are being considered. And the steering group agreed on three objectives, and that was to develop the digital tool itself, to co-produce evidence-based and easily accessible information for women. And a decision was taken that at this stage we just focus on 4 choices that women might have to make during labour. So they are the decision to be monitored, augmentation of labour, an instrumental birth, and a caesarean. The tool will eventually be widened out to include a wider range of decisions, but it was felt that it was important to proceed and to get going, but with just a few decisions to start with. And the third and final objective was to decide on what training was necessary for clinicians to use this tool. So one thing that has gone ahead during the pandemic, despite a lot of things being put back, it was the digital discovery for either side. So over the last few months, there's been a team from the digital side of NHS England looking at how this tool can be developed in practice, talking to lots of stakeholders, interviewing lots of service users and staff to make sure that the tool is going to be fit for purpose. Next slide, please. So some of the feedback we received during that testing was from women, and that the key needs that women wanted to see in this tool were they felt safe, they felt that their needs were going to be met, they felt that they were going to be given information that was easy to understand and easily accessible, and they wanted to know that they were going to be listened to and that this tool was going to give them an opportunity to have their wishes addressed. Next slide, please. And what we heard from healthcare professionals was that they wanted to have a 360-degree view of the person. They wanted to know what was important to that individual, but they wanted a tool that would enable them to focus on what was important. They wanted information that was easy to communicate and factual, and they wanted to feel sure and confident that they had taken consent correctly and covered everything that they needed to, and that this tool was going to be an enabler of that and not get in the way. Next slide, please. So where we are at the moment is that the first iteration of iDecide is being built by Badgernet, and it's just on the verge of being feasibility tested in 2 units. So that's just a quick check to make sure that all the assumptions that have been made about the tool, about internet connectivity, access to iPads, etc., are correct before the tool is formally piloted in around 10 to 12 maternity units, and that will be sometime in the new year. The pilots will then be evaluated, and assuming that this tool has been successful and has worked for both clinicians and for women, the iDecide will become a requirement for all digital maternity systems. And that will mean that the tool itself will be in those systems, and also they will be able to draw down on this co-produced, easily accessible and evidence-based information. And then the plan will be to roll that out to all maternity units. Next slide, please. So just to conclude, I think it's important to say that iDecide is not going to solve everything. It comes with a context, and it's really important that we still pay attention to the training of midwives and doctors, both in terms of the legal context and in terms of practical communication skills to have those choice conversations. We still need to do the work to raise awareness amongst women about why this is important and how they can engage in that process too. And it's also taking place against the background of the continued interpretation of Montgomery versus Lanarkshire in the courts. On the other hand, we hope that iDecide is going to be a real driver of culture change in maternity services, that's going to put front and centre that healthcare professionals need to recognise the role of women as the primary decision makers in maternity care, and we want to give them a tool to enable them and to empower them to do that. So thank you very much for listening, and I look forward to hearing some of the questions a bit later on. Thank you.
Thanks very much, Maria. So as I mentioned before, we've done a little switch around of the speakers, and the next speaker I'd like to introduce is Dr. Rebecca Moore, who is a perinatal psychiatrist with a particular interest in birth trauma. And in addition to her wide-ranging clinical practice, in 2018 she was one of the co-founders of the charity Make Birth Better. So over to you, Dr. Moore.
Thank you very much, and thank you, Maria, for swapping round. I've had a very stressful morning tech-wise, and thank you also to all the people at Owen Mitchell in the background who've been massively helpful. So yeah, I'm here to talk about birth trauma, and when we talk about birth trauma, I'm talking both about psychological trauma and physical trauma, because of course often there's an overlap between the two. And I think it's particularly pertinent to what we've been talking about this morning, because certainly consent is very, very often a common cause of birth trauma for both women and their partners, in fact. Could I have the next slide, please? Okay, so we're going to talk about what is a traumatic birth, what might that feel like, to try to think about why birth can be so traumatic, and also to think about the common causes of trauma and how we might work to prevent that from happening for women and their families, and also thinking about what we can all do in whatever role we are, wherever we're working, what we can all do to help prevent birth trauma in the first place. Next slide, please. Just a reminder, when we're talking about birth trauma, is that obviously I've seen we've got a hugely varied list of delegates today, and so please think about yourself. You know, these issues are very emotive. It may be that you have your own experience of a traumatic birth, so please do, you know, if you need to take a break from this discussion, please do. And also I think it's really important to set the scene, as because I think sometimes when we're talking about birth trauma and we give stories of people that have felt their issues have been from midwives or from obstetricians, that it can feel quite difficult if you're a midwife or obstetrician listening to that. And this is entirely to recognise that we recognise at Make Birth Better that everybody within the system can be traumatised, that particularly at the moment teams are working under enormous pressure and doing the very best that they can. And so this is absolutely not about targeting or demonising any particular group. It's about recognising that there are pressures within the system for staff working within the system that can then cause birth trauma. And it's very much about trying to find a way to improve things for everybody within maternity systems, and that includes staff and patients as well. Next slide, please. So this is one of the quotes that somebody who is involved with Make Birth Better said, and I think it really starkly but beautifully illustrates how it can feel to have a traumatic birth. So I think your first birth delivers you into motherhood. It's literally the gateway to your mother self. I can pretty much spot the mothers who have had a hard time and those that have had a positive experience. One feels empowered whilst the other feels bereft. And I think that's really, really true, and that's really good description of how a woman can go through the same experience physiologically, but can be left feeling emotionally so very, very different. There are always, it's unique to each woman, it's her story, and it's a very much a subjective experience of how your birth feels, not what actually happened on paper. Next slide, please. So I think one of the issues with birth trauma is that, you know, there is this narrative that birth is meant to be the best day of your life. And, you know, that is in essence very silencing for a lot of women because they feel they can't complain, and that sits alongside the, well, at least you have a healthy baby narrative, which is further silencing of women. So, you know, the focus becomes on baby, women feel that they can't complain, and really birth trauma is relatively new in terms of being recognised as something that can actually lead to clinical distress and PTSD. Specifically. So it's really only been sort of talked about over the last 10 to 15 years widely, and was only added to NICE guidance in 2014. Of course, it's been around for much longer than that, but it is good that there is, you know, lots more recognition and discussion and thought around birth as a trauma, and we certainly see that in terms of how new services are starting to develop. I think the other thing that is different is that it can be positive. Birth is positive for most people. So it's not like thinking about a traumatic event such as a death or a loss. So, you know, for many people, birth is positive, and that makes it further difficult perhaps sometimes for people to understand just how traumatic birth can be sometimes. And then it's harder to recognise and seek help. And the classic quote is that birth trauma is in the eye of the beholder. And this is absolutely crucial to birth trauma. So it is in essence that woman's story of her birth. It's how she feels, it's her experience, and however she feels is valid. It might be that she feels one thing was traumatic or multiple things were traumatic. The key thing is listening to that story and hearing it and validating what that woman feels. Because it is going to be, if you have 20 people in a room with a traumatic birth, they will all have very different experiences and stories. So it's absolutely always about hearing that story. And if someone feels that their birth was traumatic, then that's where we start from. It was traumatic, and we can move forward and explore that. Next slide, please. So, as I said, it's completely unique to each woman, and it's subjective and it's their story. It's not at all about what happened on paper. So often, you know, you might see women that had a very quick vaginal delivery, and people will say, aren't you lucky, that was so quick, it was so easy, whereas actually they felt completely helpless and out of control, and the baby was born at home and they felt terrified that something was going to happen. So it's not medically what happened. You know, it might be that it's a cesarean section and they felt concerned that they were rushed off to theatre and they didn't understand what was happening and it wasn't explained to them. So it's always about understanding what the trauma was for that woman, what felt difficult for her. And we're talking mainly about psychological trauma, but often there is a physical trauma as well. And it's really important to understand how closely those two can be entwined. So if people have had tearing, or they've had blood loss or other physical events, then they are undoubtedly part of the trauma as well. If we look at, you know, what causes trauma, then broadly we can divide things into thirds. So usually a third of it is something to do with something obstetrically happening. So the care that you feel you received, having an emergency, having a bleed, having to go to theatre. Then a third of it usually involves some risk to baby, or the woman's feeling that something might happen to baby. But just as importantly is about those interpersonal factors. And I think that's often what women find it hardest to think about and reconcile after a traumatic birth. So it's feeling that somebody is in the room with you, but they're not with you. They're talking about you. They're not really listening to you. They might be talking over you. They might be using very medical language, or just feeling that you feel very alone, or that your pain feels dismissed. And those interpersonal factors are really, really important, and often the things that women find really hard, because they feel that they're in birth, in labour, in a very vulnerable position and time, and that they just didn't feel very cared for. And it's something that I hear time and time again from people. So in terms of how trauma can present, sometimes it may present straight away. People may feel that they, you know, have symptoms straight away, but often it can take a while to present. So there is actually another peak of trauma symptoms for many women at 6 to 12 months after birth. So trauma can take time to percolate and unfold. It doesn't always present immediately. And it can present in a whole heap of different ways. So it might be in your mind, it might be in your sleep, it might be with bad dreams, it might be physically. Often people feel things physically, so they have pains or aches, or they don't want to have sexual intercourse, they don't want to be touched, they feel very anxious and on edge all the time, and are replaying and rethinking about their birth all the time in a way that feels that they just can't control it. The other edge of that is that sometimes people can't think about their birth at all and completely avoid thinking about it, talking about it, don't want to see anybody else that's pregnant or see friends with babies, or might be avoiding going near the hospital, for example. So it can present in lots and lots of different ways, trauma. Next slide, please. So this is another quote from one of our ambassadors. I'll let you read it through. And I think that's another common thing for birth trauma. I'm really hopeful that things are starting to change and evolve. I think there's a lot of thought within the NHS about trauma, and there's going to be new guidelines on trauma relating to maternity care shortly, and lots of services are thinking about specialist trauma clinics, which is great. But I think often one of the themes for people with trauma after birth is that they know that something is not quite right, but they don't really know where to go with that or how to seek help. And they often fall between lots of different services currently. So they might not meet the remit for a perinatal mental health team. They might have a long wait to their local therapy service. And so it often leaves women feeling in a very, very difficult and distressing place, but not quite knowing where to go for help or how to source that help. So anything we can do to make that pathway for women after a traumatic birth easier for them is going to be a really good thing. Next slide, please. So I think it's really important to say that anybody can be traumatised. So that not only includes women, but also partners. And increasingly, there's lots of, there's a bit more research around birth trauma and PTSD in fathers. Also, it's important to recognise that anybody in the birth space can be traumatised. So that might be a midwife or an obstetrician. And we know from some studies over the last couple of years that there's very high rates of trauma and PTSD in obstetricians and midwives within the UK. So it's really important to think about everybody in that space as being somebody who could potentially be traumatised. And as I've said, the trauma, we increasingly think about perinatal trauma as well as just birth trauma, because sometimes for people it's not actually their birth, it's their pregnancy or the postnatal period that's been traumatic. Of course, it can be the birth as well, and it can be one event or it might be multiple events. So it's really important to understand the whole maternity journey, because there are often things in pregnancy as well that have felt traumatic. We know that studies of birth trauma show us fairly similar rates, unfortunately, across the world, particularly in Australia, America and North Europe. But we only have a very slim snapshot of the women that are studied really to date. And we know very little about the experiences for women, for example, in LGBTQI+ families or fathers or women. Most of the women in the studies are very much white middle class. So again, we have some evidence and data, but it's too narrow a lens really for us to understand the experience for all women as yet. Next slide, please. So in terms of what might cause trauma, a lot of things can be traumatic for women. So quick labours, where it feels too fast, too out of control. And conversely, if you have a very long labour and you're getting very tired and you're in pain for a long time. In terms of pain, it's very much around the woman's perception of their pain and how it's managed. Again, it's not actually what pain relief was given, it's how a woman feels that her pain was viewed and listened to and treated. And often you have women that, on paper seem to have been given pain control, but when you talk to them, they feel that it wasn't what they wanted, or it wasn't discussed with them, or they weren't given all the options and choices, and that becomes a source of trauma. As I've said, it's very much often around feeling alone or silenced, feeling that care is sort of very matter of fact rather than necessarily there being any kindness or compassion. And that's often something that can make people feel understandably distressed. Next slide, please. Commonly feeling out of control, feeling sort of normally that you're able to control things, but often people will talk about feeling they lost their voice at that moment and they felt that they couldn't advocate for themselves as they would do normally. Clearly fearing that if you are at risk or your baby is at risk is often a cause of trauma. We have to, acknowledge racism within the system. That's often something that I hear about. And if you look at the data around maternal mortality, then there's clearly an issue there in terms of different women's experiences of the service. As I said before, I really feel we have to recognise how difficult it is for those within the system as well. And sometimes, unfortunately, this means you've got very tired and exhausted and burnt out caregivers giving not quite good enough care, and then you set up a sort of vicious circle of trauma. And that's not to criticise teams at all. That's me wanting to see teams protected and supported more, and to recognise the huge emotional burden that teams within maternity systems carry. And I think what we need to be much better at is protecting and supporting staff emotionally so that they are able to come to work and be the best emotionally that they can be for those that they are caring for. Obviously, it can be due to a medical emergency, and like I've already said, it can also be due to a physical birth injury as well. Next slide, please. So in terms of consent, that is something that is commonly a cause of birth trauma. When we started Make Birth Better, we looked at, we had 100 stories of women with birth trauma that we analysed to pull out the key themes. And there were 6 major themes of birth trauma, and consent was one of them. So it's vitally important. I know there's already been lots of discussions about, you know, how do we consent people? How do we prepare people prior to going into labour? But things that I hear all the time, sort of just to give you a snapshot in terms of consent, is people saying things like, you know, that their silence was taken as consent, that they weren't actively asked, that it was just assumed that things could be done because they didn't say otherwise. And of course they didn't, because they were exhausted and in pain and didn't really understand what was happening at that point. It hadn't been explained to them. So that's something that I commonly hear. Also about birth plans, which, you know, are contentious in their own right, but people feeling that, you know, they're asked to give choices, but then their choices are ignored, or feeling bullied and coerced during labour in terms of routes of treatment that they don't really want to go down, and then feeling that they're not truly consenting. And then I've seen, you know, lots of cases where people have been given sweeps without consent, people, all kinds of different things, but you know, leaves people feeling essentially very, very violated in some cases, because they just haven't understood what was going to be done, had any discussion about it, and it's not the option they would have chosen had they done so. So consent is something that comes up time and time again in terms of birth trauma. Next slide, please. Just in terms of birth trauma and PTSD, so about 1 in 3 women will experience some symptoms birth. So that's huge numbers of women, and of course for some women that might just be for a few weeks or a few months, but you know, these symptoms can sometimes persist for a very, very long time. And you know, every time I speak or give a lecture, you know, somebody will invariably come up to me and tell me about their experience, and sometimes this is people that have held on to their trauma and distress for 20, 30 years and never felt able to share it or talk about it. So trauma is important because it sits with people for a very, very long time. And PTSD affects about 1 in 25 women in pregnancy and after birth. So again, that's hundreds, you know, that's 42,000 women at least affected by PTSD as a result of childbirth. I suspect that it's probably more than that, because we're not good enough yet at detecting it and screening for it, and screening everybody for trauma symptoms after birth. So that's huge amounts of women and families being affected every year. Next slide, please. And in essence, to be diagnosed with postnatal post-traumatic stress disorder, then you have a checklist of symptoms which you have to fulfill all of them to have a clinical diagnosis of PTSD. So you have the traumatic event, which was something to do with birth or pregnancy or postnatally. Then you have, like we've discussed, constantly re-experiencing that. That might be replaying it in your mind, nightmares, sort of visual images of it like a film, like thinking you're back in hospital, thinking it's happening to you again. You can also get alongside that avoidance, so not wanting to think about it, not wanting to go near a hospital, not wanting to see pregnant people, not wanting to talk about your birth at all. And then you typically also have feeling very aroused and anxious. Essentially, once you've had this bad thing happen to you, you're kind of switched on all the time and expecting something else bad to happen to you. So you're scanning for risks, you're really jumpy, you're assuming the worst, you think perhaps that something's going to happen to the baby, so you're sitting up all night checking on the baby, you don't want anybody else to touch the baby. And alongside that then can come low mood, feelings of guilt, feelings of shame. So I think you can see that that's a pretty difficult place to be in with a newborn baby if you're feeling that you don't quite know how to seek support or where to go with those feelings. Next slide, please. And I think it's really important to, you know, when we talk about birth trauma and PTSD, that they're not quite the same thing. So birth trauma doesn't equal PTSD. So you don't have to have a clinical diagnosis of PTSD to be traumatized by your birth. And in fact, you know, the people I worry about most are those people that, you know, probably wouldn't check off all of those symptoms for PTSD, but would have 2, 3, 4, 5 symptoms. So that's still significantly debilitating day to day. And again, those are the people that I think perhaps can fall under the radar of services currently. So they've got really severe trauma symptoms that, you know, are sort of sitting there and can be really hard to process and to just go on and get about normal life. And typically, you know, it will impact not only on mum, but can be on her relationship with baby, on a relationship with partner, social relationships, wanting to go out. So it's a very, very hard place to be starting new motherhood from. So it's really important that we don't just screen and offer treatment to people with PTSD, because there are a huge amount of women that have trauma that still need support and care as well. Next slide, please. And I think, you know, why this is so important is because often birth trauma is very preventable, particularly if we think about those interpersonal factors that we could get better and do well for women, and also that trauma is very treatable. So we shouldn't be having women left to manage trauma alone when we have very effective, simple treatments that can cause them to feel significantly better very quickly. So there are amazing plans in place, as we've spoken about. There are going to be some new guidelines from NHS England. There's lots of focus around how do we support women after a traumatic birth, both from maternity and mental health services, which clearly is great, is a good thing. But at the same time, along that, we know that, you know, particularly at the moment, the NHS is burdened in a way that it's never been before, and also that there is a shortage of midwives and obstetricians, and that many of those are also have their own trauma symptoms going on at the same time. And there's still very much a lack of awareness of birth trauma in some people. When we ask people, you know, at Make Birth Better, often people will say they're aware of it, but they feel very unconfident in assessing birth trauma, or in knowing where to signpost birth trauma, or in you know, what they do if somebody discloses that they've had a traumatic birth experience. And as I've said, it often currently at the moment, women find it hard to know where they fit in terms of current services, and they often pluck up the courage to go to see their GP, but then they're not really signposted on anywhere, or sometimes that experience can be negative, and their symptoms can be very much dismissed, or often people are misdiagnosed as having postnatal depression, when actually, you know, they're two very distinct pathways of care. And so we often hear that commonly is that people are told they're depressed when they're not, they're traumatized. So one of the things that, you know, we'd also like to see is all people having contact with women at any point throughout the maternity service feeling empowered to know more about birth trauma and to feel skilled to be able to treat and assess and know where to signpost people onto. Next slide, please. So yeah, this is just to recap. There's some of the annual birth trauma conference that I run. I had an amazing live artist who was creating these cartoons through the day, and this is one of the ones, you know, I think that one of the key things is about people feeling heard and listened to and actively listened to, and that recognition that a healthy baby is not all that matters, that it is mum and baby, and indeed I'd rather it be family and baby, so that everybody's health is important and needs to be cared for. Next slide, please. So in terms of healing after trauma, at the moment, the most commonly offered support for people tends to be a debrief, which will mean going back to your hospital setting and seeing a midwife or an obstetrician who would not necessarily be involved have been involved in your care but would have your notes. I think the evidence for debriefing is very, very mixed. It very much depends on who does it and how they do it and where they do it. So for some people, asking them to go back to the place where their trauma took place is just too difficult. So commonly people will say, I tried to go, but I couldn't even get out the car in the car park. I couldn't walk back through the same corridor where I'd been in labour. So I think there needs to be, you know, perhaps with the new maternity outreach clinics that are being proposed, that might be one space where birth trauma reflection might be better cited, so you're not asking women to go back to the same hospital where their trauma took place. Often also women get referred onto IAPT, which is therapeutic services, but again, this can often be long waiting lists, and unfortunately this year's events haven't really made that any better. So commonly we would have people saying that their waiting lists were 6, 9, 12 months. And clearly, if you're suffering from trauma, waiting for 12 months is just not good enough. Often services offered are very good, but they might be very short term. So women might only have, say, 6 or 12 sessions. And often with trauma, you need a bit longer than that as well to process everything and to heal. So we do find actually that lots of women end up trying to source care privately as well, which obviously is a barrier for most people, and you know, means that a lot of women are excluded from treatment. Next slide, please. We do now have a specific birth trauma scale, which is very good and very quick and pretty much takes as much time as the Edinburgh Postnatal Depression Score. So one of the things that we'd also like to see is this being included into postnatal checks for everyone within the family, because it's a very easy way to start to screen for trauma. So we very much hope that this is something that will be supported by the new guidelines, and then that will enable health visitors and GPs to start to use it in clinical practice. We, on the Make Birth Better website, we've got lots and lots and lots of free crib sheets which you can download. Some half are for parents, half are for professionals. We also have a checklist where people can check off the symptoms that they might be experiencing, which sometimes can be helpful to take into a GP consultation and help just sort of promote a discussion and guide a discussion around the fact that these are trauma symptoms. So there's lots and lots of free resources there online, which we would encourage people to use and print out if they find that helpful. In terms of treatments at the moment, the main treatment for trauma for people is either usually going down a therapeutic route or sometimes medication, but also there's lots of other things, particularly bodily based treatments that can be helpful for people. So scar massage, journaling has been really well evidenced for PTSD in general. And obviously a huge explosion of things that people can access in terms of apps or peer groups or online support. A lot of people find that invaluable. They may not ever want to come and see a mental health professional because that might feel too difficult or too frightening, but they will use an online group where they can be anonymous. And, you know, it enables them to talk to other people who are going through the same experience. So that can be really, really helpful. I just put in Tetris at the end because there was a study last year where they used the computer game Tetris for people that had had a traumatic delivery. They got them to play Tetris within the first few days of delivering. And there's something about the eye movements that you make in Tetris that seem to be similar to EMDR, which is a therapy for trauma, and seems to suppress the memories becoming traumatic. So there was a lot of interest in that, obviously, because it was unusual. And I know that it's a Swiss group, they're replicating it to see whether that might be something that might be of use to suggest as an actual treatment. So typically healing after birth trauma can take time. So, you know, it's not something that often resolves for people within months. You know, for most people, it will take a good few years to feel that they're, you know, coming back to regaining where they were before. But I think it's really important to point out that, you know, a lot of women have what we call a post-traumatic growth after trauma. So at least 50% report some positive outcomes of trauma. So feeling an inner resilience, feeling that they have grown in ways they hadn't expected, feeling a renewed purpose. And I think that's probably reflected in, often you see people that use their own story in terms of campaigning or getting involved and wanting to share their own experiences. So we often see post-traumatic growth as well. Next slide, please. Just a little bit about Make Birth Better, that we are a collective of parents and professionals, and our focus is around reducing the impact of birth trauma for families. And our vision, our grand vision, is to create a world where people no longer suffer from birth trauma. We've been around since 2018 and grown sort of rapidly, which has sort of highlighted for us that there are lots of families out there that were experiencing birth trauma, and we work mainly by sort of training, teaching, campaigning in collaboration with lots of other birth organisations. Next slide, please. That's just who we are. So we're a collective of parents and professionals. We have lots and lots of members, around 150 sort of core members, and then about 15,000 members online. And you know, it's been really amazing in terms of us learning from the people that are contacting us and that are very courageously continually sharing their experiences and stories, and us being able to learn from that and think about that in terms of what we need to campaign for families. Next slide, please. Oh gosh, that looks different, and the words have disappeared. There we go. So we're all thinking about, you know, we very much think about sort of collective experience, as I've alluded to, and thinking about, you know, the whole system. So we are very much an organisation that is for parents and professionals, because whilst we recognise that for many of the families we work with, it's very difficult for them to think about that because they feel so let down by services, but we are very keen to think about the whole system, as I've talked about, and we very much feel that professionals are part of that and that we need to be supporting everyone within the system. For us, it's not either or, it's not us versus them, it's everybody within the system. We need to work together to make that work as best it can. Next slide, please. So what we work with mainly is we provide lots of support online, we do lots of training and lots of campaigning and support, and particularly in terms of the online forum, I suppose that's really grown exponentially, and we have members from all across the world really, and it's been an amazing platform, I think, to reach people. You know, I know as a psychiatrist, you know, if we talk about the hidden half, that, you know, 50% of women with any perinatal mental illness will never seek or disclose or seek any help. And I think for me, that's where social media can play such a beautiful role, actually, because it enables conversations, it enables people to feel heard and seen, it enables us to normalise things in a way that we just can't reach perhaps through sort of traditional mental health routes. So I think that's been really, really important to us, that we feel we're able to reach a lot of families that we wouldn't ordinarily do so through our social media in particular. Next slide, please.
Come back. Yeah.
Oh, I'm back now.
Okay, and so just in terms of what you can do now in terms of, you know, getting involved, if you're not already involved, Make Birth Better, please do join us. It's free, there's no cost. We organise regular events, we have a newsletter. You know, I think this is what we sort of feel is, you know, open and listening and actively listening about women's stories, wherever you are, in whatever setting, whatever your role. I think we underestimate what we can do as one person, And actually, time and time again, women will say that the biggest thing for them was when somebody just sat and listened and heard their story without interrupting, without judgment, and just sat and heard it all. So I think don't underestimate what we can do as one person, because actually we can do a huge amount for that woman at that point. I think be aware of how common birth trauma is, just so, you know, if people aren't talking about it wherever you work, start to think about it, start to look at more training, be aware that it's really common, be aware that we should be able to recognise how birth trauma might present. You know how to signpost people, not only to things online, but also what is your local pathway. If you don't know it, find out about it, find out about the services that are available also within the third sector, so that you know where to signpost people to if they are brave enough to open up about their trauma. You know, think about your services and whether you need more training or more support or what that might look like, and know how to signpost people to places like AIMS, Birthrights, Birth Trauma Association. There are so many amazing resources around birth trauma now that people can get a huge amount of support from. Next slide, please. Okay, so this is just, I hope this is going to, this is a video, I don't know if it will play, but essentially this is just coming back to the theme of language and the words we use. And we ran a campaign called Every Word Counts at Make Birth Better, which you can still see online, where we asked women to give us the negatives and the positive phrases that were said to them during their birth or pregnancy. We had about 700 negative responses, which was, some of which were incredibly difficult to read, but were incredibly important to read and to know about. And this was 2018, this was not a long time ago. But then we also had lots and lots of positive phrases. And I think they just really highlighted, you know, how subtle differences in language and communication can make a massive difference to somebody. And that, you know, words actually are so important, particularly in this time of someone's life. They have the power to harm deeply. And, you know, that we see communication as one of the key things. And now the video is playing, so hopefully you can see it. I'm not sure we've got any sound though. Don't worry if there's no sound. Okay, thank you. Can I have the next slide, please? And just to go back to the sort of Every Word Counts, that, you know, we do actually have a collated list of all the phrases, and it's actually really been helpful for us in terms of thinking about language and how we, you know, we've used it as part of teaching and training. So if anybody would like a list of that, the document, then I'd be very happy to share it afterwards. Obviously, we also do lots of training and teaching. If there's anything that we can help support people with that feel they would like to know more about birth trauma, on our website there's also a free 20-minute introduction to birth trauma training, which is completely free and anybody can access. And I think that gives a really good, slightly more detailed overview of birth trauma. So please do, you know, go and have a look at that as well if you think that would be helpful. Next slide, please. And that's a very, very brief, condensed overview to birth trauma. Normally, when I do this, you know, it's over several hours, but I hope it's, you know, at least given us, you know, a sense of the fact that this is important because it happens to lots and lots of women and families and staff. a little bit of an overview of how to recognise it, and just please don't underestimate what you can do as one person in a woman's journey. Things like listening, kindness, compassion, they really, really matter so much with trauma. Thank you very much.
Sorry about that. Back to me. I think I was so driven, and I was moved by that, Rebecca. I thought that was really, that little video clip was so powerful. So thank you for that. And as Rebecca mentioned, all of the advice and tips and links and so on will follow after today's webinar with the thank you email and of course a link to the recording itself. But before then, we've still got a bit to go. Our next speaker is my colleague Sarah Whelans, who's an associate solicitor based in our Cambridge office. And Sarah is going to talk us through some sample case studies to illustrate the experience of some of the clients, sadly, that we represent. So over to you, Sarah. Sarah will also, by the way, lead on from there into the Q&A session.
Thank you, Anne. Thank you for that. I just would like to start by thanking Nadine for telling her story. I think it's a prime example of the issues that we've touched upon today. I'm going to talk about some case examples that we've had at Owen Mitchell. But I think before I do so, it's really important to make the point that and to recognise that we do deal with the very worst case scenario, and it will only relate to a fraction of cases that you deal with. But I do think it's really important to reflect upon those small percentage of cases and see if we can learn lessons from the themes that arise from the cases we pursue. And I think the cases that do come to us are a reflection that actually there still is a paternalistic attitude to treatment out there. And I just think it's a really good reminder of the consequences of that in the very worst case scenario. So firstly, I'm going to talk about a case that I dealt with. My client suffered a severe needle phobia. Her first pregnancy was managed at one hospital trust, and due to placenta previa, she was for a planned C-section. Following discussions with her anaesthetist and in light of her needle phobia, it was agreed that that C-section would be under general anaesthetic. Unfortunately, due to a hemorrhage, it resulted in an emergency C-section, but that was still under a general anaesthetic, and thankfully with an uneventful recovery, and baby was born healthy and well. For her second pregnancy, she went to a different hospital trust, and she was advised by her consultant that she was for a VBAC delivery. She advised the consultant that she always thought she'd have a C-section because her previous delivery had been a C-section, but the consultant said there was absolutely no indication for that. And although did request her records from the previous pregnancy, it didn't alter her decision. There was absolutely no evidence within the medical records that there had been a discussion of the risks and benefits of all relevant modes of delivery, and the decision was made for her that she would undertake a VBAC delivery. Throughout the pregnancy, she became a little bit more concerned about the size of the baby. She went for a private scan at around 34 weeks, I believe, and that showed possible fetal macrosomia. She took that back to those treating her at the NHS, and they dismissed her concerns. And it was our argument that there should have been a further discussion at 36 weeks when it was understood how the pregnancy had developed, of the relevant birth methods and which was her preferred option. But there was just absolutely no discussion of this. And in fact, there was a discussion of the benefits of VBAC delivery against the risks of a caesarean section. It was our case that in light of her needle phobia and her concerns in relation to fetal size, that a discussion of the risks of VBAC delivery, and in particular an instrumental delivery, should have taken place. Unfortunately, my client underwent what was classed as a successful VBAC delivery, but it required the use of forceps. She sustained a 4th degree tear
requiring immediate repair. There was a suspected shoulder dystocia, so she was put into the McRoberts position, so it was fairly traumatic, and actually materialised that baby came out like this, which accounted for the tear. She was discharged from hospital with a catheter and a colostomy, and when I went to see her, she was trying to cope with a toddler and a baby with a catheter and a colostomy. Physical recovery took years, and she hasn't got there yet, and a number of medical procedures, and I don't actually think mental recovery will ever be achieved. She felt really aggrieved that the risks of this occurring hadn't been discussed with her, that her experience was classed as a successful VBAC, yet she felt it wasn't in any way successful, apart from, of course, she obviously had a beautiful baby who thankfully was absolutely fine. And it was argued from our perspective that if she'd been presented with the facts, she would have elected a planned caesarean section under general anaesthetic, as had been planned with her first child, and wouldn't have suffered any of the injury that actually did occur. The second case study relates to a 39-year-old woman, her second pregnancy. Her first pregnancy resulted in a miscarriage. It was an IVF conception with consultant-led antenatal care, and induction of labour was planned for 40 weeks. At 38 weeks, she experienced a spontaneous rupture of membranes and presented to hospital. She was just discharged and told to return the next day for induction of labour. Contractions increased in strength, so she shortly returned to the maternity triage. She was taken to the antenatal ward until she was 4 centimetres dilated, and then transferred to the labour ward. Heart rate was continuously monitored by CTG. Throughout the monitoring, she felt that something was not right. Her and her husband raised concerns to the midwives, but they were just reassured. This was not escalated to the obstetricians until much later that evening, when the obstetrician decided to undertake an instrumental delivery due to a failure to progress. She was taken to the theatre, and baby was born by instrumental delivery early the next morning in poor condition, required resuscitation and transferred to the local neonatal unit. Cooling therapy was initiated, and the MRI scan reported on day 4 a HIE around the time of the delivery. Since baby's been diagnosed with CP affecting all 4 limbs. An investigation highlighted substandard care that was provided, and the CTG trace was not properly interpreted, and at least a 1-hour delay in recognising a pathological trace. The parents were devastated and blamed themselves for not arguing with staff and insisting that they be referred to the obstetrician. The third case study relates to a woman who had a long and traumatic instrumental delivery in 2012. This caused a 2nd-degree tear, and she also developed rectocele. 2 years later, she became pregnant again. Due to the trauma she had experienced, she had huge concerns about a vaginal delivery, and requested a caesarean section. This was discouraged, and she had a number of discussions throughout the pregnancy with midwives, consultants. She was referred to a counselling service and had a number of sessions with them. But despite this, she just felt all her concerns were ignored, and that she was brainwashed into preparing a birth plan that ultimately she wouldn't have elected if those treating her had listened. She desperately sought some advice from a urogynecologist that she'd seen previously as to the consequences of a vaginal delivery. He suggested that an instrumental delivery was probably best avoided, and noted the considerable psychological impact that her previous experience had had on her, and her absolute fear of a traumatic delivery. Despite that, those treating her and those supporting her in pregnancy ignored her clear instructions for a caesarean section, and put pressure on her to adhere to their preferred mode of delivery. the risks of a further instrumental delivery were not explained to her, despite her concerns about this occurring again, and the focus was just on a repeat vaginal delivery. Unfortunately, her fears did become reality, and she had an even more traumatic birth the second time round, requiring the use of instruments. She suffered a further tear, requiring repair, and an exacerbation of her prolapse, which had and still has long-term impact. She suffered a postpartum hemorrhage, and she suffered significant psychological trauma. And she said she felt bullied into proceeding with a vaginal delivery, and wishes she had ignored those treating her and insisted on her preferred mode of delivery. I mean, those are only a real short selection of some cases that we've seen at Irwin Mitchell. But actually, I think there are key themes there that need to be pulled out. You know, women feeling bullied and intimidated, a failure to listen and communicate. I think communication is just so key. And then, you know, reported concerns being raised that are just dismissed. I think Nadine's point earlier that she felt that they were making decisions for her without her is key, and I think all of the women in my case examples would agree that that's exactly how they felt. So I think we can learn a lot from that. I'm conscious of the time, and I know we've got a lot of questions to get through, so I will leave it there, but I hope that selection of cases does give you an idea of the very worst case scenarios that do end up on mine, Anne and Julianne's desk, and hopefully through this type of discussion we can avoid some of those cases coming to us. So James, I think let's pick up some questions that have come through. There have been some amazing questions, and I don't think we're going to be able to get through anywhere near all of them, but I think we'll pick out some of them. Just to make the point that the recording will be circulated post-event for use afterwards, so you will be able to watch this back. So the first question is, what is the view of recording the conversations or discussions about risks and benefits to support decision making? I think years ago, KCL, I'm assuming that's King's College London, did some work around this. I don't know if Nadine's with us, but I think she indicated that.
Sorry, I was on mute. I'm sorry.
That's okay.
Can you hear me okay?
Yes, absolutely.
No, all I wanted to say was I'm sure that there's many other panel members that could give a more coherent answer, but I just really wanted to say that I think recording is an absolutely brilliant idea from both perspectives, and the GMC guidance now that came out just recently talks about that from the doctor's perspective, but also from the patient's perspective. I think as long as the patient isn't doing it covertly, because I think that suggests lack of transparency and trust, and that's kind of quite a dangerous route to go down. But from a perspective of as well, when things don't go right and there's a dispute, is obviously really important, but also the onus is on the patient. I think it's always really important to remember the onus is on the patient to prove what was discussed. And how can you do that if you can't, show the case notes? We can only say what is in the case notes, so you have to hope that it's been documented. So recordings, I think, are absolutely fantastic. That's just all I wanted to say.
Okay, does anyone else have anything to add, or shall I move on to the next question? James, I think this is one that you could possibly answer. It's come up, but I think you included it within your top tips. What do the panel think a midwife should say when a woman, when presented with a complex decision in labour, asks what the midwife would do? This happens quite a lot. Women often want reassurance that they are making the right choice.
Yes, that's one of the things I deal with in those practical tips. What I've said there is pretty straightforward, really. That it's important not to impose your own choice or wishes on the woman, but it's perfectly reasonable, since it does come up so often, to say, listen, you and me are different people. What I would do isn't necessarily something you'd agree with, but for myself, if it were me having this baby now, I would choose to go ahead with the course that I'm proposing to you. But in the end, if you want to consider the other options or you want to talk about the risks and benefits, I will. But that is certainly where I would be if it were me in your position.
Does anyone want to add anything to that? Any other panel members?
I was just going to add that I think it's important to try and turn it back to the woman and what she's already said. So, you know, you could say, from what you've said, I understand that this is particularly important to you. So based on that, I would say that maybe this is the best option for you, but obviously it's your decision. So, you know, I think there are ways of doing that doesn't leave the woman hanging. You know, I think people often do want that reassurance and don't want to feel they're left on their own, but that isn't about your personal values. It's sort of focused more on theirs.
Thank you, Maria.
My position too.
Okay, so the next question, and I think Nadine and Maria might want to address this, and anyone else, where the proposed management is planned vaginal delivery and the woman declines the management, the doctor is forced into caesarean section in a situation where he or she may feel, rightly or wrongly, that it is not the safest option. This was not the case in Montgomery, as caesarean section was clearly warranted. Does the obstetrician have any autonomy? Maria, do you want to take this one?
I can certainly start. I would say that the obstetrician's role in that situation is to support the woman's decision. Their role is to advise the woman on the different courses of action, the risks and benefits of both. The woman doesn't have to make a decision that they agree with. That is, you know, that is the ultimate outcome of women having autonomy. And, you know, in that situation, the obstetrician's role is to support the decision and go ahead with the caesarean. If they really do not believe that they can do that on the basis of they feel that would be doing harm, then, you know, individual doctors have the right to step out of that situation, but they need to make sure that there is somebody else who is able to carry out the woman's wishes.
Nadine?
Yeah, I mean, I completely, obviously agree with Maria. Ultimately it's down to the patient to decide. I think that there's a wider discussion to be had there about, you know, why a patient maybe particularly wants to go down a route that might not be deemed in the healthcare professional's idea as, you know, safest or more risky. And it could be that, you know, looking at the specific patient with their own specific set of circumstances, something is deemed as, you know, unreasonable. And I'll just give you a quick example. My sister, she opted for an elective caesarean section after she was so traumatized by what happened to me. Now that probably wasn't the safest, or maybe it might not have been, I don't know, but for her that was really, really important, and the obstetrician had to respect that was her right to do that. And I think the new GMC guidelines talks about that as well. I think it's paragraph 48, right? I'm not sure, somebody check that, but it talks about that and respect their choice. And the Montgomery test, sorry, maybe James can go into it a bit more, but it actually talks about that. So there's this objective limb to it and there's a subjective limb to it too. So legally speaking, it gives the right to be unreasonable for whatever your reason could be. You know, the hand example that James talked about, that's important for one patient, but for us we might think, well, that's a bit bizarre, but you know, so it talks about that, and that's where we are legally as well. So,
can I just add something as well? Just from a psychiatric mental health perspective, you know, how I see this is that I commonly have people referred to me because they are requesting a caesarean. And that's all the information that's given for the referral, is that this is a lady who wants a caesarean. And so my plea would be that, you know, not everybody who's requesting a caesarean needs or warrants or should be being referred to a psychiatrist. I think it comes back to communication and understanding, you know, like people have said, why is that woman making that choice at that time? And also recognising that women are perfectly capable of making that choice and being informed and understanding that choice. That doesn't mean that there is a mental illness there. And I get so many referrals for people where it's simply about should this woman have a cesarean? And I will say, well, that's not my decision, because if there's no mental health issue there, it's about discussion between the obstetrician and the woman. But that's something that commonly happens as well. I think people can be quite bullied around cesarean sections and often referred on to mental health as though somehow that there's an issue there, when very often there isn't at all.
Okay, did anyone else want to make a point on that question, or shall I move on? No? Okay, so next question. The biggest concern that I have is for women whose first language is not English and for whom they may have limited understanding or capacity to make decisions when they attend in labour, late booker, transfer to another unit or complex safeguarding, e.g. trafficked. Frustratingly, government public health information leaflets are available in limited number of languages. Using interpreters in labour is not ideal, often due to the time constraints and availability. Are there any plans, considerations to the specific groups of women? Maria, I think you were going to deal with this one.
Yeah, it was just to say, I can really mainly answer in relation to the iDecide tool, where we've had a lot of conversations around the importance of the tool being accessible and useful to those groups of women as well. It's got to be workable for everybody. So I know the digital team have been speaking to women with various kind of additional needs, if you like, speaking to them who are got hearing loss or got autism, or who don't speak English as a first language. So it's definitely something that everybody is bearing in mind. I don't think the tool's going to be, you know, all singing, all dancing from the off. It will be an iterative process. So it might be quite sort of limited to a number of decisions and limited to quite generic information to start with. But those groups have not been forgotten, and, you know, the later iterations of the tool will certainly seek to address those concerns. Just to say as well that we did some work with birth companions and research into the experience of women facing severe and multiple disadvantage, and that work is on our website. And you know, the experience of those women is generally horrific. They're generally at the worst end of not being able to have a say in their maternity care and not feeling like they're able to give consent. So it's really important that we focus on the experience of those women and make sure that those women feel that they have a right to have a say too.
Thanks, Maria. I think we probably have time for maybe one or two more questions. Sorry, I know we're running over a little bit, but these are all really important questions, and there's just so many good ones. So as a midwife and advocate for women, I often struggle with consent. Is it true consent, or is it conforming to societal expectations for fear of judgment over her decision? To go against the norm is a very lonely place that takes an enormous amount of courage. I feel this is particularly pertinent in cases of termination. Empowerment is an integral part of any caregiver's role in approaching consent. Maria, do you want to start off with this one?
Yeah, I mean, those are really important and sort of big questions, aren't they, about where we all kind of pick up our attitudes towards birth. And there's a lot of discussion, I guess, in the birth world, isn't there, about the fear that there is in our culture about birth, and where that's come from and what we can do to alleviate that. But I think it's really important that we have those discussions at the macro level, but also don't impose them at an individual level. I think that's where a lot of the pressure about cesareans come from on individuals. So if that woman wants a cesarean, for example, because she's scared of giving birth, then she should be given one. We might argue about where that fear's come from and what we should do about it, but for that individual, it's really important that she feels respected and listened to at that moment in time, and that, yeah, we really listen to women where they are and that they feel able to make a free choice. That's the role of the healthcare professional, to put that woman in a position where they feel that at that moment they can make a free choice about what's best for them. Thank you.
Thanks, Maria. I don't know if anyone else has any points on that question. No, I think we probably have time for just one more. It is also crucial to provide the evidence behind any intervention. There is no robust evidence that vaginal examinations or continuous fetal monitoring improves outcomes for women, but lots of evidence that can both affect the physiological process of birth. So I think that's more of a statement than a question, but does anyone, I think Maria, you might have had a comment on that one. Sorry, I keep coming back to you, Maria.
And just to say, I think it's really important that we give the evidence about these interventions. I think if healthcare professionals are suggesting monitoring, for example, they need to say why they want to do that, what the potential benefits are, but also what the evidence is that it works. And yeah, I think that's what it comes down to, is, you know, healthcare professionals being aware of the evidence behind these things that are considered normal practice, and being happy to go down a different route if the woman doesn't want that. Thank you.
Thanks again.
I would mention in that regard, there was a very big Dublin study when they compared penile auscultation with continuous monitoring, and said there was no difference in outcomes when it came to the incidence of cerebral palsy. There's been a lot of discussion of that study since, suggesting that the midwives who clung very steadfastly to the idea of intermittent penile auscultation were extremely assiduous in those cases, because they knew it was under the searchlight or the spotlight. But I think that the general agreement on the evidence since that study has been that it was probably skewed by reason of the fact that the midwives were acting out of their normal methods. But I don't think you have a great deal of opportunity, frankly, with pregnant women or women in labour to discuss learned papers and so on. You just have to make your own mind up what your thinking is about it and share it with the woman.
Thanks, James. Thank you, James. I think we've run out of time for questions, I'm afraid, so over to you, Anne.
Thank you all. I'm sorry to have to draw such an interesting discussion to a close, and I'm aware that lots of questions haven't been answered in this discussion. We've posted something to the web chat, and hopefully if your specific question hasn't yet been addressed, we can deal with that afterwards when we send out further information and of course a link to the recording itself. If we were in the room together, if only, I would ask you to show your appreciation for our speakers in the traditional way with a huge round of applause, but for now they'll have to make do with my thanks, and I'm sure all of yours, to James Badenoch QC, to Nadine Montgomery, to Dr. Rebecca Moore, and to Maria Booker. Thank you also to all of you who've joined today and for all of the questions you've put forward. As I mentioned, the fact sheet will follow by email, and you'll see on screen some slides relating to our charity partners, Birthrights and Make Birth Better. Again, links to both of those organisations will appear in the email and fact sheet to follow. And finally, as Julianne said at the outset, this is the first of what we hope will be a series of webinars on maternity matters, the next of which is likely to take place in the spring. And we hope to be exploring issues in that webinar raised by the worryingly high mortality rate for non-white women, which was highlighted in the recent Embrace report. So watch this space. We'll send out further details closer to that time. And in the meantime, keep well, everyone, and thank you once again for joining us today.